Hi, this is Elliot Fishman, and you make the call. What you make the call is, I give you one slide, which are two images, and you tell me the diagnosis. So very, very focused. Let's get started. Lower pelvic pain in a transplant patient. There are nodes in the mesentery, and there are bulky nodes in the left lower quadrant you can see here. Mesentery, nodes. When I see a transplant patient with bulky adenopathy, you have to worry the patient has developed a post-transplant lymphoma. Yes, you could say, well, could it be other things? Many things give you nodes, but newly diagnosed, bulky nodes, transplant patient, renal, liver, whatever, cardiac transplant, it's lymphoma. And this was a marginal zone lymphoma in a patient a number of years past renal transplant. Hematuria. You look at the left kidney, there's decreased attenuation, but particularly on the right, they look wedge-shaped. You could think about pyelonephritis, but when I see things that are wedge-shaped, I got to think about infarction. I have to think about vasculitis. Obviously, if you had all the images, you would look carefully at the vessels, look for any occlusion, look for any pruning. And this was vasculitis in the left kidney. Again, pyelo and infarcts and vasculitis can look very similar. If you look real superficially, the more you look with pyelo, perirenal involvement is more common. You'll get a urinalysis. With vasculitis or infarcts, you'll often see other organs involved, but you'll look carefully at the vessels. Hematuria, a huge left renal mass. Again, not very vascular, though some vascularity. I would have said a renal cell carcinoma, classic, maybe papillary, could not exclude clear cell. This was an unusual lobulated mass, and I put this case in just because it was so large. Interestingly, this ended up being a chromophobe with aggressive features. Chromophobes often have a central scar. Oncocytomas have central scars. I've never seen a chromophobe this large, though I thought I would share it with you. Not the diagnosis I made, or even in the future will make again. Patient has fever. You look at the right kidney, there's stranding. There's a dilated renal pelvis, and there's air in the collecting system. Air in the collecting system, unless you've had a recent procedure, is infection. The stranding around the kidney is infection. The abnormal enhancement around the kidney and of the kidney is infection. The patient had FUO, and this was emphysematous pyelonephritis. We don't see it that commonly, a bit more common in diabetics, more common in patients who have bad medical treatment, like nursing home patients. It's often a surgical emergency, and patients will need a nephrectomy. Patient had a pancreatic mass with a negative biopsy. Look at the spleen. There are multiple splenic lesions. You could say sarcoid, but you may have to say lymphoma. And when you look at the pancreas, the biopsy may be negative, but look at the masses involving the head, body, and tail of pancreas, but there's no intrahepatic duct dilatation. So I got to think to myself, what else could this be? It could be mets to the pancreas, but now I've given you the spleen. What about lymphoma? This was lymphoma of the pancreas. Can present as solitary masses or multiple masses. Can present as diffuse infiltration. Can present with bulky adenopathy. But just a really nice example of lymphoma. This was an incidental finding and was followed. This was thought to represent a CTisus adenoma. It was a younger female. They even considered an MCN. Finally, this was the fluid did not help much. The patient was having more symptoms. This was removed, and it was a lymphangioma. A good point to make is sometimes things that look like pancreatic masses aren't. Again, if I looked at this case, I would have said CTisus adenoma. I might have mentioned MCN. I might have mentioned pseudocyst with the right history. But if it's there and it's been there for a while, and the fluid is not classic, lymphangioma is a good thought, and just a benign lesion, and the patient will do fine. Abdominal pain and a big mass by the tail of the pancreas. Yes, I really can't say it's not coming from the stomach or the adrenal or the retroperitoneum. Very vascular, or tail of pancreas. Tail of pancreas, it could be a metastasis. It could be a sarcoma. A bit unusual look for an adenocarcinoma. Could be a neuroendocrine tumor. This patient was in their 30s. This was resected and was a pancreaticoblastoma. Pancreaticoblastomas are usually in single-digit age patients and children. They're rare, and they really are rare in adults. And this is one of those cases you say, wow, that's a great case, but I did not make the diagnosis on my first guess or my second guess. A really tough case. Incidental finding. Cystic lesion, tail of pancreas projecting outward, no dilated duct. I could think about a lymphoepithelial cyst that often compresses the pancreas, well-defined and low density. This could be a mucinous cystic neoplasm, good location, no dilated duct. Serous cystadenoma, I guess a possibility. Pseudocyst would be considered with the right history. This ended up being a mucinous cystic neoplasm. Remember, women in their 40s, typically body to tail of pancreas, and no pancreatic duct dilatation are the classic findings. Incidental mass in a 30-year-old female, solid and cystic. Again, could be an MCN, a bit young. Could be a SPEN tumor. They're usually in teenagers and 20-year-olds, more common in women by 9-1. And this was a SPEN tumor. Remember, whenever I see a younger patient, particularly female, and they have a pancreatic mass, large or small, I'm always going to consider a SPEN tumor. SPEN tumors, once resected, have a greater than 90% cure rate. Weight loss, left upper quadrant pain, a big spleen with multiple vascular lesions. There also is a vascular lesion in the tail of the pancreas. Well, if you only had the spleen, you could think about an angiosarcoma. They're typically very vascular. You can think about metastasis to the spleen. Things like renal cell can do that. Neuroendocrine tumors can do that. And you have a mass in the tail of the pancreas. Perhaps it's a neuroendocrine tumor tail of pancreas with splenic metastasis. That's a really good thought. This patient had biopsy and eventually surgery. This patient had a renal cell carcinoma which metastasized to the spleen and the pancreas. Just a really nice example. It does make the point that the kidney with clear cell gets all sorts of vascular metastasis. In the pancreas, it's often more than a decade from the original presentation. Well, that's a bunch of cases. Hopefully the discussions help you. Hopefully the single pair of images made you think deeply. And hopefully you learned something. And with that, have a great day. If you like this video, make sure to subscribe to the CTisus YouTube channel. You can also visit us at CTisus.com for even more videos, plus quizzes, pearls, protocols, and oh so much more. We're also in the App Store and have well over a dozen apps for iPhone and iPad, all completely free. Thanks for watching.